The first speaker will bring the best practice of customer-centric service from Japan. Actually, I and she are friends for a year. She's my friend of friend, and when we keep in touch for a long time. She has two licenses, midwifery and nursing. She got master degree in public health from London School of Hygiene and Tropical Medicine, UK, and PhD in medicine from Kitasato University, Graduate School of Medicine Science, Japan. Her experience is amazing. She used to be a fellow of International Action Program in Montreal, Quebec, Canada. That's why she can speak French very well. Moreover, she used to work as an expert of JICA project in maternal and child health in Brazil for 3 years. And I think today she will have a good experience from that project to share with us. Last but not least, she is a program consultant on disaster management and education for Japanese Nursing Association and an associate professor of Sophia University. I give you Dr.Yae Yoshino. Please welcome her. Please, Dr. Yoshino.
Thank you so much for your kind introduction of myself, and I'm very privileged to be invited for this special occasion. And I'm not sure if I'm good enough to talk about the situation in Japan and overseas, but I'll try my best. And if you have any questions, please stop, or in the end of the lecture, please ask me question, anything you want. So let me get started. Oh. So how can I start the slide? Oh, so I was given the topic to talk about patient or person-centered care, and this is such a common practice here in Japan, and somehow very ordinary that I had to read through the literature again to know what is going on in these issues. And then having seen some histories and literature review, I found it's been not so new concept itself. It's been introduced in US sometime around 1960s, and then came to Japan around I think late 1990s, and same thing happened in Thailand. But I think in implementation in the clinical practice, it's been around decade time since it's been introduced, and still there are a lot to do, and something has been very well improved, but there are some other things need to be worked out. And I found those terminologies are quite similar and somehow confusing which one would be the most accurate, but those are the ones that I found in the literature review. So, and I didn't think those are the different concepts, but the way how and who talk about this issue, they named differently, but basically the concept is quite common in the background. And customer centricity was a new term for me. I have never heard here in Japan, and I think it is more in Thailand rather than here in Japan. And this was a definition from Forbes. It's an economic journal, not from the health sector, but they talk about to understand customers' situation, perception, and expectations. And customers should be at the center of all decisions related to delivery of products, services, and experiences to create customer satisfaction, loyalty, and advocacy. So it is customer-centered or customer-centristic. That's what it means on the business sector. And when it comes to the health sector, they often use person-centered care or patient-centered care. This is a very similar concept. And I think when people who don't call it patient, it's not, it's because patient not necessarily always have the disease itself. So to make it wider perception, I think they choose to say persons-centered care instead of patient. So anyway, person-centered care or patient-centered care it's the same thing that they focused on the person's uniqueness or preferences rather than disease itself or symptoms, diagnosis, and challenges and loss ability of this person. So I think the biomedical model, the doctors tend to look at the patient as a body or the mechanics or the part of the body to focus on the diagnosis. But I think the nursing perspectives, we look at the person as a whole. So it is something not so new for the concept of nurses, but it is new for doctors, I would say, here in Japan. And this is something to be careful with the situation, how we look at the situation. It's focusing on the person's world and through the eyes of the particular person. So if we diagnose or if we look at the person, we just cannot see their experiences as a person. So it is a different shift, the shift change, how you look at the situation. And patient-centered care is very similar, and this is from the NHS in UK. And consultation is based on open communication with the patient, listening and reflecting, or using providing questions, explore patient experience and concerns. And patients are encouraged to be actively involved in their own care and have access to their notes and correspondence. So the communication between the medical professionals and patient has to be therapeutic alliance, and both has to be participated in the dynamic process of the caring or curing. And this is a quote from the NHS. The one patient said, "No decision about me without me." So doctors tend to make a decision or diagnosis without having involved the patient as a center. And value of the customer centricity in healthcare, engage consumer as a partner, is a kind of new concept that the consumer itself is a patient, but they pay for the services and they has to be the center of the attention. And this would be very effective to making the more effective health services intervention. And this action can be save money or improve self-esteem of the patient or improve quality of life of themselves or their family or achieve better adherence to practitioner recommendations such as medication or treatment recommendations, and cost effective can improve outcomes at the same time. So if the healthcare professionals doesn't think patient as a participant or the partner, we ignore their desire or ignore their involvement, so that outcome can be poor. And this is a conventional or traditional medical model and physician-centered care. The healthcare provider tend to give the diagnosis, treatment, prescriptions, or solution finding, or referring, or guide to the care planning. And often patients, even here in Japan, have no voice. Physician at the outpatient clinic, often they talk, and patients barely ask questions or ask their will, how they want for the treatment. So kind of paternalism existed in the medical field. And doctor-centered interactions tend to be, doctor can be an active giver of the care and patient can be a passive recipient. And this isn't really ideal, but unfortunately, still this is today in Japanese hospitals and clinics present. So maybe you have already known about those definitions and concepts already, but I have no idea what kind of textbook you are using, and please bear some of all other concepts that I'm going to talk about. But three things are very similar, like disease and illness and sickness. We sometimes use those terms in the same way, but actually it has a very different meaning how you use this term. And the disease itself is often used by the healthcare professionals. This is for more like physiology, sorry, my English, physiology based or abnormalities in organs or body system. Like we look at the blood test or X-ray or some lab test. Those examination results the resources to define what is the disease. And on the other hand, illness is an individual experience of mental or physical sensations or the state or may not be necessary to indicate presence of disease. This is kind of confusing because sometimes you feel dizzy, but doesn't necessarily to be a disease itself. It's possibly a temporary condition of your health or sometimes simply psychological disorder or some stress causes one point of time like headache, but it is not a disease. But when we call it sickness, it is includes both disease and illnesses. So illness is what the patient feels when he goes to the doctor, but disease is what he has given on the way home. So the doctor is talking about the disease while the patient is talking about illness. So that interaction in between the doctors and patient are sometimes not in good shape. So this is how I try to describe what is person-centered care compared to the traditional or conventional medical model. And we have to look at the patient lifestyle or personal histories, preferences, values, knowledge, beliefs, and cultural backgrounds, goals, wishes, desires, and family or the community. So those are the things are not in the conventional medicine, but we start to look at more with the person as a whole to understand what is the meaning of the patient saying according to those knowledge and also having those knowledge about the person as a whole, we can connect to the team of the medical sector so that we can make a planning on the treatment or make the care planning or wellness planning that very much depend on the person's wish so that we don't give the tailored, not like, it is like orthodox kind of services for everyone, but we tailor the healthcare services depends on the individuals. So patient and family make their own decision and own choices. So this is very basic things, and traditional medical models tend to look at the person's diseases, and as I said earlier today, and this is also said by Professor Thomas Kitwood in late 1980s in England. So it's been quite long, like 40 years ago. The concept has been already shared in the UK. And conventional healthcare and people-centered care have some differences on the focus on relationship and care type or responsibilities or partnership. And this is a report from World Health Report from WHO in 2008. And conventional care is focused on the illness and cure and limited to the moment of consultation. So it hasn't got the continuity of care. And care types is episodic curative care, only focus on the disease or only focus on the ill health, but not the person as a whole. And responsibility is limited to effective and safe advices to the patient at the moment of consultation. Again, it is only the moment they have meet, but not before or after. And the partnership is often to be the users or patients as a consumer, and they buy the services, while people-centered care is focusing on health needs, including physical, psychological, and mental, sometimes spiritual needs, depends on the condition of the patient. And the relationship is enduring personal relationship, which is the mutual kind of conversations and communication existed in between the patient and the health care service providers. And care types are comprehensive, continuous, and person-centered care. And responsibility is health of all in the community along the life cycle and tackling determinants of ill health. And partnership is people are partners in management of their own health and that of the community. So it is not stopped by one person, but it's family included and the community itself is also included. So those are the desired outcome of the person-centered care, better overall experience with healthcare system or greater satisfaction with quality of care. This is both patient and healthcare providers and greater likelihood of better health outcomes so that this is cost effective and also the satisfaction level is higher. So why not to implement? And this is a dimension of the patient-centered care introduced by Netherlands PICA Institute in Netherlands last year. So there are a lot of different kind of guidelines or concepts include 6 dimensions or sometimes 4 dimensions, but this is the least, this is, I think, the newest, and it includes everything that I wanted to include in this lecture so that patients' preferences and information and education, this is only not only for the patient, but also family. And also nurses and providers has to be very informed before they deal with the patient. And coordination is, this is a lot to do with interdisciplinary teamwork, and I will talk about it later. And emotional support and physical comfort, family and friends, and continuity and transition. So those are the 8 components of the important dimension of the people or patient-centered care. And this is another one from Canada, Ontario, Canada guideline for the cancer care. Very similar, like knowing patient as an individual, understanding essential requirement of care, tailoring healthcare services for each patient, continuity of care and relationship, and enable patient activity participating in their care. So this is a very interesting YouTube video if you are interested in watching, very simple and easy to understand. I will give this PowerPoint slide to Dr. O in the end of the presentation. I'm sorry, I should have sent it much earlier. I was told to send 1 week earlier, but until this morning at before the sunrise, I've been working on this slide and couldn't make it to send in advance. This is my big apology. And to achieve person-centered care, we would like to, we would need to activate patients and family members armed with knowledge and skills and motivate participate as an active member of the care team to extend their willing and able. Those are the things seems to be most challenging for health providers to work on. And the 6 domain of interaction with the patient and family, those are the things already I have talked, and there are many duplications amongst those concepts, so I just skip. And what is opposite customer-centric care? And we should think about what is opposite of the concept. And logically, this is a physician-centered care, and physicians have begun to incorporate patient perspectives in the ways increasing matter. So they look at the illness and pathology itself, but then they focus individual patients' needs and concerns rather than the doctors. So it is happening in 2012 or mid like 2015 in Thailand and Japan. They start to have the medical guidelines like clearly declare what is customer-centric care. So beforehand, they are more likely illness-oriented care was most domain of the healthcare system. And person-centered care has been adopted successfully in Thailand This is according to the journal, International Journal of Nursing Science from 2020. And it seems like Thailand nurses has been working very well, and they have been successfully achieved to have the family strengths and individuality. So you are the one that I think one of the best nurses in the world to achieve those strengths. But while we look at the strengths, there seems to be a weakness on patient-professional collaboration or design of healthcare delivery system. Those are the things most nurses in Thailand in this study in Mahidol University are pointing that family-centered care or person-centered care is a Western concept, and nurses' weak attitude towards their roles and shortage of the nurses are the reason why it hasn't been really achieved those patient professional collaboration and the delivery system. So this can be the next step towards your goal, and then you can strengthen the person-centered care in Thailand. And this is a study from the Netherlands, and it is very common, and you can find it is very similar with the Thailand and the Netherlands and also in Japan. And the patient preferences or access to the care, physical comfort, family and friends, emotional support, information and education, coordination of care, continuity of transition are the similar. For instance, like not all the patients want to be actively involved, especially when it comes to the children or elderly. They are not really keen to be the participant of the care itself, but rather they want to rely on the doctor's decision or family's decision instead of their own willness or their needs. Or the access to the care depends on the financial situation, or if the access to the care in the countryside or in the city is also differ very big, and physical comfort is also depends on how it's being offered by the GP practices. So those are the things I think when you look at the barriers of the barriers to implement the person-centered care. Those are the things is the tangible target for you to work on. So let's see if you can work on the workshop. What is your problems in the community or in certain institutes, and look at the reason and rationale, and you can find the solution by yourselves. So I would like you to look at those the barriers after the lecture if you have some times. And healthcare professional perceived person-centered care implementation barriers. This is another quote from the same journal in Netherlands. And achieving mutual understanding between patient and healthcare professionals are difficult because they have different languages and different understanding of the physical situation, and also they don't use the same language. So we need to know how patient understanding the situation and how they perceived the diagnosis or the treatment itself. Or professionals' lack of training and education in the new skills is also the barrier to realize this person-centered care. Or data protection laws. This is about the Netherlands, and it impedes adequate documentation. Or information sharing or time pressure, because nurses are always very busy that they have to deal with many tasks in a very short time, and also the conflicting financial incentives as also is an issue, and including the shortage of nurses is an issue to achieve those person-centered care, because it takes a lot of energy and time and effort to make it happen for individual needs. And Kitasato University Hospital, Japan, this is one of the biggest university hospital in Japan, where I used to work 13 years before my current university, Sophia University in Tokyo. And this is her quotes in the regarding the patient-centered care. And she said, since the opening of the hospital, interprofessional team has been working in collaboration and harmony. And we have proved patient-centered care in an equal relationship. Just as there are patients with different cultural background and values, we need the diversity of our staff. We believe nurturing a strength of our staff will lead to diversity and positive outcomes in the patient care. There is no point in being a nursing profession if you care for patient does not lead to the good result. And the interprofessional team work is in this Kitasato University is one of the pioneer to start this education program for undergraduate students, and more it is all sort of health alliance professionals students are gathered in the holiday season. Despite our will, they make the big gathering of the students to give the case studies to talk about how we look at the patient through the biomedical perspective and social scientific perspective. So this is a international team, interprofessional teamwork, and to have like such as the nurses are the center of the interprofessional team. This is very certain that each time my nursing students participate in this training program, they realize they are the key person of the entire interprofessional team in the hospital. They coordinate the different professionals, the paramedical and physicians, to have the best result and best practice of all the professions involved in the practices. And we often be the closest person to the patient so that we advocate their will and desire to the team, and we collaborate over those the professionals. So the translation, like the practice questions come then after evidence and translation, and practice and we reflect, and learning and reflect. So we circulate this kind of thinking in the hospital every day. And this is a interprofessional education program, which is called IPE program. And more uniquely, at Kitasato University, we invited foreign students from different Europe and Asian countries to have the interaction. So multidisciplinary and cross-cultural training program to expand academic exchange, to create more interdisciplinary focus, and also educate healthcare professionals with the ability to be active worldwide. So it's a big aspiration to work on, but we gave the student the 4 case scenarios. It can be any sort of diseases or situation, but those case study has been working quite well for different the student with a different culture and different disciplines. So that diabetes and complications, stroke or lung cancer, multiple sclerosis, with a goal setting either hospital stay or after discharge from the hospital. So let students to talk about the biomedical understanding of the situation of the patient and the family. And we talk about the possible teamwork and who want to be involved in the care planning, and also what is the resources, like social resources, such as the health services free of charge, or you have to pay, or whatever. And goal for the patient, understanding of different healthcare system of different countries, especially on insurance coverage. So Japan, we have the UHC services, which is universal health coverage. And elderlies over 65 years old, they only have to cover 10% of the all expenditures, while my age, who are working in the companies or universities, whatever, is has to pay for 30% of the all expenditures. And we don't have the difference between public hospitals or the private hospitals. So the services are even, and we can choose whatever we want and wherever we want. So this is a free of choice when we come to the hospital. And the influential factors on the medical care plan, so that the policy implementation or the nurse law, laws related to nursing or education or the scope of practice, etc. And care plan is different standpoint for the care plan reflected and cultural differences or an insurance system in each country. And at the end of the program, each group demonstrates the result of a series of fruitful discussions. So we try to make some ideal case study, like it is not necessary to be realistic, but what can be the best kind of practices to make it person-centered care with the different disciplines. So those are the participants, 6 countries and 14 different disciplines, and over 150 students gathered in one spot for 3 days, very intensively. So this is quite interesting, and students really love, so that I believe your young nurses to have this kind of opportunity, not necessarily international, but domestic, to have the multidisciplinary teamwork can be very fruitful. And this is a YouTube video I would like to show, but I think the time is not very long, so I will leave it with you. So when you come to the slide, please have a look at the this interdisciplinary training program in Kitasato University. And case study in Brazil, I would like to talk about my experience in Brazil. Brazil is a very unique country, and that people tend to choose cesarean section, and wealthy population, over 90% of the women choose to have the cesarean section, while the disadvantaged population takes a cesarean section 40 to 60. This is the highest rate in the entire globe, and the reason of this happens is a policy or health insurance coverage for the cesarean section is very high, so that they tend to use the services to have more gain. And also having cesarean section is easy for doctors and the patients, because the Brazilian people doesn't like to suffer from the pain, like contraction pain for over the days after. And doctors like to cut because they are very skillful for cesarean sections. Only 20 minutes they can cut and stitch the uterus, and very, very fast and very, very efficient, because they have been practicing almost all the time the cesarean section. And cesarean section is being so popular and almost like a norm in the country. At the time of the admission in the hospital, women are all shaped and secure the IV lines, and they are forbidden to have any eating and drinking during the delivery, so that they are starved to death. I mean, they have a glucose IV, but they cannot eat or drink. Even glass of water, they have been restricted. And they do have the frequent public examination and little privacy and respect, so that women tend to be very stressed and tensed in the time of the delivery. They don't have the privacy, and they can barely rest in between the contractions. And also little information were given before and after the delivery, so that they don't know what is happening with the pain, when it strengthens the pain, and when comes to the water block or the bleeding or some meconium have been included in the discharge. And also few choices of women are hard, like body position or movement or presence of the loved one, like they are not being able to have the partners present at the time of the delivery. So lots of women had suffered with weak hypotonic contractions, ended up in cesarean section. So this is biomedical side of view. You say when you have the lack of glucose, it will decrease the contraction, and it ended up in cesarean section. And also this is a choice of the people and choice of the doctor. So then it has been, for ages, they have been doing the same practices.
Giống chặt nè.
Oh, is that the time?
Phải này nó phải này giống chặt. Cấp phải này lỡ chặt.
I'm not sure, but I still may have time.
Cấp này phải lỡ chặt là gần.
And
越讲话
let's see. And when I see the situation, especially prohibiting intake, eating and drinking was a big problem. And I wanted to talk with a medical doctor in Brazil, but they were worried about having, if they choke during the cesarean section, like emergency cesarean section, they would worry about pneumonia caused by the choking. And then I should have given the evidence from the literatures so that how many minutes, how much amount of the water or tea or sweet drinks can be taken.
ปิดตาซ้ายนี่เป็นไผก็คนปิดตา
What
ขวา
can
นี่เป็น
be
ไผ
the safe limit.
หมายถึงคนที่ปิดที่เราอ่อนเป็นไผแน่ก็ไม่เข้าเพราะว่าคนไผ
To convince the doctors, we have to provide the scientific evidence through the literature. And this has happened 20 years ago, and it wasn't very easy for us to talk evidence-based medicine. But it is important to use the language of the doctors.
วัดถ้าเป็นเขาไม่เข้านี่นะจะลำบากเพราะว่า
And physician-centered
จะค่อยๆกินขึ้น
VS
ขึ้นเมื่อวานโดยที่แบบ
women family-centered care. And on the left-hand side, this is operation room and also the delivery room. They use the same room for delivery purpose or cesarean section, and they have sometimes at the same time they have the cesarean section, two patients together, and they have no privacy, and it is very, very cold in this room, and the bed is flat and very hard, so women have such a discomfort to give the birth on this table. While this is the countryside, when the traditional birth attendant are using in the countryside, where the obstetrician trained them with the biomedical knowledge, so that this is easier for women. If you think about the women-centered care, this looks primitive, but this is much easier to push the baby, and it takes shorter time to have the baby out of the womb. And in Brazil, a person called Paulo Freire, this is a very famous pedagogist from the 1970s, and he have introduced participatory problem posing education. And this is very interesting to interact with the student, or it can be interact with the community or young nurses as well. It is not like a banking type of education, like we don't provide the knowledge through the lecturer to the student or participant, but instead we ask the participant to talk about their problems and what is their issues like to resolve. And so this is not we teach, but we actually learn from the participant. And this has to be something very practical issues to be discussed, and the participants and facilitators are co-investigators for the problem. So we look at the situation and we sit down in a big group, or it can be small groups, and we just focus what is the possible barrier of not being able to implement the person-centered care. And then participants start to talk about, because of the financial issues or the communication between the doctors or hierarchies or policy or whatever, they talk freely about the situation and the problem, and they themselves start to decide what the topic they will focus on. And facilitators will keep silent for the first session of the workshop. And the second day, they start to talk about, this is an active approach. It's like a bottom-up approach. We let the participants to work on the concept. For instance, like we don't really teach how the conception happens, like a pregnancy happens. We let them discuss within a group of the traditional birth attendant or nurses in the community to let them show what is their thinking and what is their perceived problems or challenges, so that we can observe through their practices and their concept or their perception. And so this is a 4 days workshop pausing education process. And so this is a day one free discussion amongst participants and deciding the topic and clarification of the current problem, finding answers by themselves and discovering and answering together for their questions. So the supervisors or facilitator will not say anything, but we present in the group discussion. And only the second day we give the knowledge, scientific-based knowledge from the physicians or other health professionals or professors, and Q&A with the participants. And day three, we look at the participant, how they understood the knowledge and information given. And day four, those participants will present what they learned from the workshop and share with the audience, which is other participant of the group. And this was a sex education program for all gender age in a small remote village in Brazil. So it is like 10 teenager boys and teenager girls are in a separate group, and 60 years or over women and men are in the different groups. So we make a group of the people in a different age and different sex, and then let them have the discussion over the 4 days time. So in the end, we gather and share the knowledge and compare and look at the problem that they have found, and also they have also found the solution by themselves with the possible social resources and alternative kind of ideas. And this is a top-down approach, where the one I explained previous slide was a bottom-up from the community of the nurses. But this is a top-down approach collaborated with the VIP doctors or OBGY professors, those who have a power. So he was Federal University's president and also the president of the OBGY Association. So he has a big power on his word. So we become very good friend of him, and we ask him to talk through his voices to let them understand what the message we want to bring about women-centered care in Brazil. And those are the countryside doctors who have a power, like small prefecture hospitals directors. And this doctor have a voice, and he transformed those doctors in the community. So it is something important that we cannot work from the bottom-up approach only or top-down approach only, but we can cooperate the both approaches at the same time, and it can bring the good result. And what happened after this combination of the approach in Brazil 2 years time while I was working, the mutual communication enhanced strengths both healthcare professionals and women health and spiritual growth and the empowered. So those people who are involved in those workshops has been started to realize they have a voice, they have the will, and they have a desire to health professional, as well as professionals. They didn't really look at the patient as a human, but they realized they are the human as they themselves, just like sisters or mothers or their friends. And through the training program, skills improved, like enhanced observation, or assessment skill has been enhanced, so that they have more confidence in their practices and strengthen professional responsibilities and commitment. I think because of their skills are strengthened, they have more responsibilities to achieve the better outcomes. And the salaries hasn't been increased by these approaches, but they have the higher job satisfactions and they have a higher self-efficacies, so that having involved like a participatory method can make the participant, both nurses and midwives or the community women, both happy about their situation. And culture to implement better practices was created, because it is difficult to make changes in a healthcare system, so that if you make the environment welcomes the changes or challenges, once you make it happen, then it is easier to propose something new something can be challenging or difficult, but people already know that it can make the better outcome for themselves and for their people. So this is 20 years after the intervention. I've been back to Brazil some years ago, and I saw what is remaining and what is lost. But overall, the concept of women-centered care has been alive. In a Catholic-based hospital, like a mission hospital, has been very active in preserving the ideas or concept of the women-centered care. But unfortunately, prefectural hospitals were all closed down, the maternity services, because of the lack of the financial securities. So this was unfortunate. And this is a humanized care unit of the maternity hospital. This is a private hospital, and they gathered all the beautiful concept of the all over the world to make the best environment in Brazil. So this was surprising that natural childbirth wasn't really happening in Brazil, but 20 years later, the people start to have active birth as it is in Europe, but it's in a better room and better condition of the environment. And nowadays, 2080, WHO introduced interpartum care for positive childbirth experiences, and WHO tend to make the safer guidelines like practices based on the death or to limit the number of deaths or immobility of the patient. But this is the very first time to look at the women, their respect and dignity or privacies, or the companion of choice by their side, or clear communication by maternity staff, supportive care with oral fluid and fluid pain relief strategies throughout labor, or mobility in labor and the birth position of choices. So this was something we promote in Brazil 20 years ago. And actually that JICA project was the first project to talk about the humanized birth care based on the women-centered healthcare model. So it was luckily, it was my great fortune to participate in this big movement of the paradigm shift from the physician-centered care to the women-centered care. So it was introduced in Lancet, also in New England Journal of Medicine, or all other international conferences and guidelines, so that it's been still working in Africa and Asia in the third and fourth generation to promote this women-centered humanized care. If you look at the JICA project website, you can find humanized care, which is the same as women-centered care. So this is a women-centered care that WHO recently published in the guidelines. It is the same thing as the person-centered care, the concept. It is more than 8, it is 9 concepts to be included, but always has to be the continuity or dignity or respect or communication and the family involvement. So thank you so much for listening to my lecture. I hope it was understood.
Yes, thank you, Dr. Yoshino. You have a good experience. And it's good for nurse or midwife who work with the women or in the community health nursing. Your experience that you share today is we can apply. As you mentioned that this concept is familiar with customer-centric, people-centered care, patient-centered care, women-centered care, blah, blah, blah. And it's come to Thailand for maybe 4-5 years, as you mentioned. But why we still put up this topic to this program? Any Thai participant can explain why this matter for this concept. Can I have Ajahn Nakarin, because he's the one that he convinced this topic will be in this program. Ajahn Nakarin. Are you ready to respond something and explain something why we put this topic? You, okay, because we have a short of time. From my experience, that our staff, we do our job as an nursing quality assessor, particularly in the hospital, in the Ministry of Public Health, and we realize that even we force the nurse to concern about the patient-centered care, family-centered care, blah blah blah, but we lack the patient and family population that you show in the model. And I think what they have a process that they ask for the patient need or family need, but when they analyze the data, what to improve the nursing quality is still in nurse or professional nurse or healthcare provider perspective. It's not tracked from the prevalence of the patient and family. So just in some model, in some area that they can do this in the best practice. That's why we put this and we discuss this again. And we would like to push the perspective of marketing, that we use the term customer, because it's not only the patient and family, but we have some other stakeholder. So we have about 5 minutes left. Any participant would like to share or would like to ask something from Dr. Yoshino, please raise your hand. Okay, I saw one. Wait a minute. Miss Prang, please. And then Miss Prang, and then Kun Sangop, and then the last question must be Kun อะไรนะอุกฤษเหรอ
ชัชลินค่ะ
Okay. Miss Prang first.
Thank you, teacher. I would like to introduce myself. My name is Prang Muthakamise from Chiang Rai Province, Thailand. At the beginning of this section, you talk about caregiver. How about caregiver burden situation in Japan? Because in Thailand, caregiver is often found more.
The question, I would like to clarify the question. So the caregiver is who in Thailand? The elderly. I'm sorry, the microphone wasn't really clear to me.
She asked about caregiver role in Japan, because here in Thailand, we have nurses shortage, so we need some like a health volunteer to take action as caregiver, and is very important role for the health volunteer. So what about in Japan?
Yes, we have the nurse assistant as well as volunteers, and we have some special profession. It's more or less new, like 15 years, 20 years ago, we made a new profession only for elderlies. So those who have education for 1 year, if I'm not wrong, and they do look after the elderlies at home, or it can be in the facilities or in hospital. I don't know how to translate in English, but I can check it in the dictionary later, and I will give it to Dr. O. We have some people, and also those people are very big shortage, and we are now having a lot of Asian specialists coming to Japan. I think the Philippines is the biggest country where we invite, and also some people from Vietnam and Indonesia. Those are the ones who come to Japan to help us. So I think the market of those elderlies are very big here in Japan, and we are having opened the gate for the foreign laborers. But the government is a little bit stupid and they are not really planning ahead of time. So I'm not sure how it's going, but we have the different professionals to support nurses. Thank you.
As same in Thailand, in some area, mostly caregiver is very important for the elderly, particularly in the bedridden elderly. And maybe Miss Pang, you can this question we can get some more sharing from Taiwanese speaker because they have a very good for providing this caregiver. Okay, next question belong to คุณสงบ เชิญค่ะ please คุณสงบ
Yes, it was amazing topic for today that I learned from you. One of the most reason why we continue like a client center in Thailand that I want to share with my teacher and all of you. And I has experience that I integrate client center to my job in Thailand. I am a psychiatric nurse. I work at the psychiatric hospital. I use client center to like a motivation interviewing to like we have state of change for patients and we have to make a plan with client and we have to ask for the plan first what to do and the goal that you want to come. That's why we integrated that and something that we have a problem with this is we misunderstanding with them because we have a guideline for do this but we don't to correct like a two-way communication with them. That's why we have a problems. The client center we look at the client and family and then we can see the real communication or we can see the truth that they need. That's why I like to use the client center in my hospital. Yes, this is my experience. And I have a question for you. And I read the journal that you did that you writer about based learning and continuing education program, right? I read your journal about based learning and continuing education program in maybe in Mongolia.
Yes.
Yes, I want you to explain about that because this situation like COVID-19 and this beneficial for us because this is a technology and we use like a technology to do the same like you and could you explain the key success to sustain web-based learning program and the limitation that you have to improve about that. Thank you.
Yes, thank you very much for your comment. And I think it is very famous. Thailand have a community health workforce. You have a big, good communication and models, and we learn from Thailand a lot. So there are a lot of things that I learned from Thailand. Besides, the Mongolian project have a long story to tell. It's been over 20 years I've been working with Mongolia since 2002. And at that time, it was long before the COVID-19 pandemic. And the Mongolia is 4 times bigger than Japan, and they have a very poor infrastructures, such as electricities and telephone or internet facilities in the countryside. So that many nurses in the remote area have no opportunity to get the continuing education after the graduation of the diploma or universities. For 20 years time, they have nobody to come and teach them the accurate knowledge of the medicine. So that when I went to the field work in the countryside, they complained how they feel insecure about their clinical practices. And I gather the voice of the people in the countryside, and I bring back to the Minister of Health and talk with the Mongolian Nurses Association to discuss what is how can I say, the critical issues we have to teach and what is the needs of the nurses who works in the front line. So that we discuss a lot what is the priority while we have the very limited time and very limited financial resources. Actually, I only have very small amount of money of my own to start the project. But luckily, I was able to talk with the WHO representative in Geneva. I jumped in to the seminar they organized in Japan for the Ministry of Foreign Affairs as an observer. I become friend with the chief executive officer of the WHO Maternal Child Health Division. And I asked his cooperation to give the guidelines and seminars, provide lecturers on the satellite system. We didn't have a Zoom, but we had a satellite system through the World Bank system, so that we collaborate with the World Bank and the WHO to have the WHO knowledge and information together with the World Bank facilities and Japanese knowledge. We combined everything and then we choose the topic. And in the end, what happened was like a basic observation without equipment, like expensive equipment, because they cannot afford to have those examination tools, but they have to do their observation or assessment by themselves in the front line. So that we try to make it as basic as possible, the component and evidence-based medicine, so that nurses in the front line or midwives in the front line were able to learn something skillful and useful, but not conceptualized, but more like skill-based training through the website. Like we try to teach them resuscitation of the babies, or like a blood or hypertension management of the women, so that very critical management of mother and babies, and also very basic observation and assessment. Those are the topic we choose. And yes, it's been 5 years project. I have been collaborating with WHO and the World Bank. Unfortunately, their interest moved to Africa and they no longer want to work with Mongolia. But in individual basis, I still am a friend with the nursing officer in Ministry of Health, as well as Mongolian Nurses Association headquarter member, so that we cooperate and coordinate distance education programs through the Zoom. This is free of charge, but it's only cost for the translation of the text and the interpretation of the lecture, because I don't speak Mongolian at all, even after 20 years of the interaction, unfortunately. So that has to be Mongolian and Japanese, or English and Mongolian. So those are the things I have to be thinking when you plan. But I would be very happy to work with you. I love Thailand so much. Dr. O took me to the beautiful places like temple and beautiful restaurant and garden. And I really like the country. This is unfortunate. This is online seminar today, but I wish I can come back sometime soon. So let's talk about it.
Okay, thank you, Dr. Yoshino. And Kun Ukrit and Kun Chachalin, could you please leave your question in the chat box, because it's run out of time. So after this session, after this speaker, we will take a break for 3 or 5 minutes, and then we will switch to the second speaker. And thank you, Dr.Yae Yoshino, for your good experience, and it's amazing experience that you share with us today. And welcome to Thailand. If the COVID-19 is stopped, so please come to Thailand. I will take care of you, and then I will show the waterfall that last time you came here, and we don't have time to go to Kanchanaburi. Next time if you come, I will show you a beautiful waterfall. Okay, thank you very much.
So much.
Please give a big applause for our speaker.
Thank you so much.